Hello, my name is Patricia Field, and I'm a fourth-year medical student at University of Nevada, Reno, presenting our case report about pediatric lupus, worked on by myself and my colleagues Rodney Fong, Paul Makabulag, as well as our mentor, Dr. Kukalan. Pediatric lupus, or childhood-onset systemic lupus erythematosus, abbreviated here CSLE, is an autoimmune disorder often affecting mucocutaneous, musculoskeletal, hematologic, and renal systems. Despite being a diagnostic challenge, especially in the outpatient setting, time to diagnosis is an important prognostic factor as pediatric lupus is characterized by more morbidity and higher mortality than its adult counterpart, and delay of that diagnosis could lead to irreversible damage and poor quality of life. Given that 10 to 20% of all lupus has childhood onset, and the relative wealth of literature on the adult onset condition, and the fact that available literature in pediatric lupus is female predominant, we'd like to describe this atypical case. So in this case report, we describe a 10-year-old Hispanic male who, by the time of diagnosis in the hospital, had neuropsychiatric, gastrointestinal, renal, and musculoskeletal involvement. His constellation of symptoms, of course, made sense after the diagnosis of lupus was made. He had multiple hospitalizations for unexplained abdominal pain, indicating his gastrointestinal involvement, and high blood pressure signaling potential renal involvement. He then developed gradual onset, worsening bilateral joint pains, limiting his ability to walk, indicating musculoskeletal involvement. In the 2 weeks prior to hospital admission, where the diagnosis was made, he developed recurrent high fevers, daily nosebleeds, likely the hematologic involvement, and significant weight loss, which is worrying in a small child. In the hospital, his labs indicated severe anemia, abnormal coagulation results, and high amounts of protein in his urine. On an abdominal CT scan, there was renal edema. He developed seizure-like activity and had a PICU stay for several days. Head imaging and EEGs were unrevealing. Blood tests were obtained and eventually came back positive for multiple markers for lupus. Management and treatment of this patient required not only the hospital team, but also input from pediatric hematology oncology, infectious disease, nephrology, and adult rheumatology. He was found to have significant renal involvement and something called lupus anticoagulant hypoprothrombonemia syndrome, which is a rare syndrome associated with pediatric lupus that predisposes to both bleeding and clotting. Thus, time to diagnosis was crucial for this patient to prevent potential long-term irreversible complications. There are multiple sets of criteria for lupus, but the main ones developed are for adult lupus, and although there has been a pediatric lupus criteria proposed, including things such as developmental delay, we have not found it widely used in our literature search. And as I've said before, this patient's constellation might have said pediatric lupus in retrospect, but constellations are difficult to ascertain when a star is missing. So in this case, that star was the lack of mucocutaneous involvement. Things like oral or nasal ulcers, or the famous malar rash, or demographics such as being a reproductive aged female, some of the key components to making this diagnosis. In addition, ANA, a test highly sensitive but not specific to lupus, is only useful if the clinical picture fits. The blood tests, although helpful, aren't what ultimately leads to a lupus diagnosis. It's that clinical picture. And given that pediatric lupus's presentations are highly variable and dangerous if not detected quickly, we felt it imperative to help characterize this atypical presentation and bring awareness to this condition. Thank you.